just to read out with our usual school books. This is age 10, 11. And it was then I began to be interested in science. And so I started reading books, would you believe, on physiology and anatomy and things like that at that age. And I've no idea why, really, because no one in my family had ever been in medicine or nursing or anything like that. But I just got interested in that. And that was really the first step towards me thinking, yes, I'd quite like to do medicine. So it wasn't, I think, ultimately because I was desperate to save mankind. It was actually, I was interested in biology. I was interested in what made people tick, but also, even at that stage, what things could go wrong when there was disease. I moved around a little bit, as I say, and then I ended up in Glasgow to finish my schooling, and there I decided for sure I was going to go for medicine, and I entered medical school age 17, and in those days in Glasgow there were no interviews, and it's just as well because I was very immature. I would have stumbled through any interview. I would have crashed. I would not have got in. And I've still got kind of mixed feelings about the roles of interviews, so because I might not have been here when I was interviewed at this stage. Anyway, I really enjoyed life as an undergraduate. Really from day one, I thought it was a fabulous place to be. In those days, we were given the opportunity of doing an honours degree, equivalent to honours here, but it was a 2-year degree, and you could either take that after second year or third year. And I'd really enjoyed my first couple of years, but I decided, no, I'm not going to do honours. I want to be a surgeon. I was absolutely sure I was going to be a surgeon. And so at the end of third year, having said, no, I'm not going to do an honours year, we did an elective, like your Dean's elective. And I chose to do that in a small country hospital, a cottage hospital really, in the south of Scotland, in Ayrshire, in a place called Ballochmyle. And any of you heard about Robert Burns, Robbie Burns? It's a very famous Scottish poet from the 18th century. Anyway, all his countryside is around this Ballochmyle and Ayrshire, and I had a great time, fantastic. Worked for a surgeon who was a really delightful chap. He took out gallbladders in the morning, and he tended his sheep in the afternoon because that was his other part of his life. And at the end of the 8 weeks there, I thought I really had enjoyed myself, but I'm not sure that cutting out gallbladders really is what I want to do. And I didn't really fancy the life of a farmer either. So anyway, I decided at the very last minute, before I was supposed to enter fourth year, literally the day before we were supposed to enter fourth year, I knocked on the door of the professor of pathology and said, look, I've changed my mind. Is there any way I can do one of these honours programmes? And actually, somewhat reluctantly, they said, well, it was a bit late in the day, but then reluctantly, yes, we'll take you on. And that was one of these bits of almost chance, or maybe not chance. I did make a conscious decision I was going to do this, but it was very much last minute. And it has shaped what I then went on to do, because in the 2 years of the honours degree there, first year was just sampling lots of different projects, lots of different techniques, and I actually did a summer project with another professor, not this one here, Professor Rab Gowdy, and I did a project on thyroid disease, and in particular thyroid cancer. And he had some antibodies against thyroglobulin. You've all heard of thyroglobulin? And he figured that we could use these antibodies to actually light up bits of tissue that would tell us that a tumour had actually come from the thyroid gland. And that's something that's now in routine use in all pathology labs. But in those days, that really hadn't been kind of thought about properly. And he had been interested in thyroid disease and had generated these antibodies to thyroglobulin. And we did these experiments, which really took about 3 or 4 weeks, and they worked beautifully. And I got a paper in a good high-ranking journal, got to present at lots of meetings. And I thought, this is great, science is fun, and it works. And if you just work hard, you'll always get these good papers. And of course, that's not always the case. I then went on to spend the bulk of my honours projects with Sir Roddy McSween. And actually it was harder work in terms of the actual science. It didn't work so well, although we did get a paper out on the basis of that. And this was more around the liver. And this was my first entree into liver disease, and we demonstrated that in the serum of alcoholics who have advanced liver disease, there are antibodies which react against their own liver. In other words, perhaps those who go on to get more advanced liver disease when they drink, it's partly an autoimmune phenomenon. Now, it probably is actually not all that important, but nonetheless, in those days it was fairly innovative, and again, it was fun, although it didn't work quite as smoothly and as neatly as the work on thyroid globulin. But it got me working with Roddy, and Roddy is a truly inspirational guy who was head of pathology in Glasgow, who then went on to become the president of the Royal College of Pathologists in the UK, and then the president of the presidents of colleges. In other words, he took over all of the colleges in the UK for which he got his knighthood. But he's a delightful guy, works around the clock, or worked around the clock. He's still alive and reasonably well, and still remains a close friend, and still my mentor. So he really was a true inspiration to me, and it was he that really lured me back into pathology. So, having done my 2 years as an intercalated honours student, I had to go back and finish my medical degree. So I did 2 more years, and I really enjoyed that. I particularly enjoyed rather diverse subjects of obstetrics and psychiatry, and the chairs of both of those different disciplines wanted to encourage me to do this as a postgraduate. But actually by that stage, I really had decided I wanted to do something to do with the liver. And that could be as a surgeon, it could be as a physician, or it could be to follow Roddy's footsteps. So as an intern, in those days we had to do 6 months surgery, 6 months medicine. I did my 6 months medicine first of all. I was just starting my 6 months surgery, and I decided what I would do is apply for the physician rotation and get my MRCP with a view to doing gastroenterology and then hepatology. And one afternoon as an intern, I got a phone call from Roddy. He said, "What's this I hear you've applied to be a physician? Forget that, I've got a job for you." And of course nowadays you just can't create jobs for people, but that's exactly what happened. And I said, "Okay, right, I'll join you." And so at the end of my internship, I went straight into pathology. I do, to some extent, regret not having the opportunity to have done a medical rotation. I think that would have been quite useful. But as it happened, if I had done that and then elected to do pathology, there wouldn't have been any jobs for me because the way things had worked out in the UK. So again, it's all about being there, being in the right place at the right time. And you may not see this very well, but this is me as a senior house officer, like sort of just immediately after an intern. I'm the only one without a jacket. Obviously wasn't getting paid enough in those days. But I enjoyed my training there. I enjoyed working again with Roddy, and we started doing quite a bit of work together, particularly on alcoholic liver disease, but also on autoimmune liver disease. And one of the things when I was doing my honours year, my final honours year, which I was really privileged to be able to do, was to proofread the very first edition of Roddy's book, Pathology of the Liver. And actually this is the Bible, not the Mears is often regarded as being an important book, but this is sometimes described as the Bible of liver disease. And so Roddy wrote that, and it was ready for proofreading, and I got to go through it, line by line, and it just absorbed so much. And then subsequently, I've had the great pleasure and privilege of then being able to edit this book, which we now call McSween's Pathology of the Liver. And I'm glad to see that remains the main international book on pathology of the liver and how to interpret liver biopsies. And in fact, there's a 6th edition, and I've just commissioned authors for the 7th edition. So that's good fun, and it really keeps you on top of your game. All right, so why would I be interested in liver disease other than just being inspired by Roddy? Well, liver disease is sometimes a bit of an orphan. It doesn't always get a lot of airplay to undergraduates or indeed to many postgraduate settings. But it is an important part of our landscape in terms of healthcare. Certainly in the UK now, it's the 5th largest cause of death. And if you look at younger ages, it's much higher up the league table than that. It is different in different countries. In the rest of Europe, in fact, liver disease is more plateauing now, but these are death rates here, comparative death rates in the UK over a number of years from different diseases. Many diseases are plateauing or going down, like deaths from cancer, deaths from heart disease, but this is liver disease. So astonishing increase in the burden of disease. And this is largely in the UK the result of two things. One is alcohol, and the other is fatty liver disease because of obesity and diabetes. More alcohol than the other, but the other is beginning to catch up. So, as a postgraduate, I was happily working along, getting some publications out with Roddy, being trained in histopathology as a general histopathologist, but then also taking a particular interest in the liver biopsy interpretation. By then, Roddy was getting involved with the college more, and he was away a lot, so I began to take responsibility for some of the meetings and the biopsy interpretation. So it gave me that kind of responsibility, which I think benefits you when you're at that sort of later stage in training. But at a particular point, I had a desire to just do something slightly different, and I applied and was awarded a Peel Trust travelling fellowship, which took me to the Free University of Brussels, the VUB, where I worked with another inspirational chap, and that's him here. This is Eddie Wisse. And Eddie Wisse was the scientist that really put the liver sinusoids on the map. Now, you might remember, you've done histology, that the liver has got all these capillaries, they're called sinusoids, and you probably just think they're boring and they're just, the blood flows through them. Eddie really put these cells of the sinusoids on the map and characterized the different types, the endothelial cells, which are very different from endothelial cells elsewhere, the Kupffer cells, and some other cells which I'll talk about more in a moment. But I went over there to work on the synthesis of complement proteins by the Kupffer cells. And the Kupffer cells, you might remember, are the macrophages, and they line the sinusoids. And Eddie had been, in particular, was a great ultrastructural biologist, so he was good at the electron microscopic features of the sinusoids, not just in a sort of almost a two-dimensional, but they did lovely scanning microscopy and showed all the various holes that are in the sinusoidal endothelial cells and so on. But in his department, they also had devised ways of extracting the different cell types from the sinusoids out of animal livers, and being able to put them into culture, and then to look at their function in vitro. And that's why I went across there to do the complement biosynthesis. That turned out to be a pretty dull project. Yes, the Kupffer cells produce a bit of complement, C3, but then so do other macrophages, so what? But again, just being in the right place at the right time, I got working with a chap called Burt Geertz. And Burt was about my age, and he was a cell biologist, not a medic, and he was interested in another cell in the liver, and these were, in those days, called the Ito cell, and we now call them the hepatic stellate cells. And I'll show you some examples in a moment. And these, we now realize, are the real engine for driving liver fibrosis and cirrhosis. And he, at that stage, had found a way of getting these cells out of animal livers, again, so we could look at function in vitro. So, alongside this, I didn't give up looking down the microscope, because close by, this was in Brussels, close by, in a place called Leuven, was another fantastic pathologist called Villiers de Smet. And so I used to traipse to Leuven every week to do the clinical pathological meetings with him. And so I maintained my skills and interest in the diagnostic histopathology of the liver while I was there. And this here is an old photograph. That's Villiers de Smet. And I show this photograph because, again, some of these are real inspirational leaders, and I've had the fortune to work with a number of these. And this group is a group that we're meeting since 1967, and it's the group that first defined most of the terms that you hear about in liver disease. So chronic hepatitis, a lot of the other sort of definitions of chronic hepatitis was due to this group, and the way that we assess liver biopsies in terms of how much inflammation, how much scarring, was again this group, the so-called Ishak score. You wouldn't have come across that, but all pathologists will have come across this. This is the way that we score how much disease there is in biopsies from patients, for example, with hepatitis C or other chronic hepatitis. And this group, as I say, got started in 1967, and at that time there was a lot happening in Europe in terms of the financial sector, and there was a sense that there was people in Switzerland were carving up financial institutions for Europe, and they were referred to as the gnomes of Zurich. Now, it so happened that the group that I've shown you here didn't invite one very important person, and that was Dame Sheila Sherlock, who really ruled British liver disease. She was a clinical hepatologist, and she wasn't invited. So she began to think that this group was carving up hepatology, and she named them the gnomes of liver disease. And she was using that as a sort of as a really almost scathing remark. But it's a name that really stuck, and that group is still called the gnomes. And it still meets annually to talk about specific aspects of liver disease and produces position papers. And I've had the real privilege of being a member of that since about 1995. And we take it in turn to host, and I'll be hosting it here in about a couple of years' time. So it's a great meeting to go to, and we are all sort of friends that keep in touch throughout the year. We always have some jokes like so at the end of each person's talk at the meeting, we have some sort of photographs like that. So I did want to say a little bit of science, not too much because this is a Sunday afternoon, but just to give you some idea about what I got up to then as a postgraduate, having been inspired by Roddy to get interested in the liver, having been then inspired by others in Belgium to get interested in the liver sinusoids, and in particular in those cells that we now believe are the ones responsible for scarring. Because at the end of the day, liver disease, the effects of liver disease are largely because you lose the critical mass of the normal cells and you replace it with scar tissue. So we need to understand what it is that switches on the scarring, and is there anything we can do about that? Once it's scarred, can we get rid of it? The answer is yes, probably. And on the way to cirrhosis, can we interfere with it such that it's not going to be so advanced disease and so on? So I'm sure that you're all aware that there are actually many ways in which the liver can be injured. Many ways in which the liver can become injured. There are a number of inherited metabolic diseases, alcohol, viruses, and I've alluded to already fatty liver disease because of obesity and diabetes, and autoimmune disease. These are the main types of injury. But common to all of those is that however they injure the liver cells, it leads to inflammation. And the inflammation, as in any other organ, that can, over time, if these are persistent, lead to scarring. So part of the response to any injury is inflammation and the laying down of some connective tissue really to act as a scaffold on which the organ can repair. But if it keeps going, if that connective tissue keeps getting laid down and there's insufficient replication of the normal cells to repopulate the liver in this case, then you get fibrosis. And in the context of liver disease, when you get fibrosis, it can develop into a cirrhosis, and that carries with it quite a significant risk of the development of cancer. So I've been particularly interested in this bit here, the inflammation to fibrosis, and how can we tackle this, how can we understand it? And if we go back to a little bit before I began to be interested in the liver fibrosis was regarded as being something where the scarring was really just because everything else collapsed. You lost the liver cells, and so everything collapsed, and that was really post-necrotic collapse. But it was this chap here, Hans Popper, who sadly died a number of years ago, and I only met him on a few occasions, but he was really the person responsible for the whole study of hepatology. Before him, that wasn't really a discipline. A really enormously bright individual. And he was the first to say, no, this is not just a passive thing. This is actually a dynamic process. This is something that's actually happening in real time. There's more scar tissue being produced. And actually, not just that, potentially that could go in the opposite direction. It could regress if you got rid of what was causing the fibrosis in the first place, and you might conceivably get resolution. And now we actually believe that some forms of cirrhosis potentially are reversible. In essence, though, fibrosis is a net accumulation of all these matrix proteins, but it's not just that they're in excess amounts, but that they're in different quantities. So you might know that there's different types of collagen. So you get different ratio, for example, of type 1 to type 3 collagen and so on. A lot of detail, it's not really important, but this causes, all that scar tissue causes a space-occupying effect. In other words, it kind of strangles the sinusoids, and so blood doesn't get through the liver as easily, and so that's why you get portal hypertension. It's also then why you squeeze out the hepatocytes and they're not working so well. But the other thing is that the matrix around the cells also controls cell function through things called integrins. Anyone heard of integrins? Sort of signaling molecules that link the matrix proteins to gene transcription. So in the liver, it's just like any other form of wound healing. You get loss of liver cells for whatever reason. You get the release of a number of cytokines and chemokines that switch on inflammation, switch on also proliferation of the surviving cells. You get, with the inflammation, the formation of new blood vessels. And in an ideal world, all of that repairs what has been lost, and you go back to the normal tissue. But if the agent that's causing the injury is persistent, then the inflammation persists, some of the new blood vessel formation persists, and you get persistent activation of myofibroblasts. We'll come back to that in a moment. But the myofibroblasts are the ones then that lay down all that connective tissue protein that then causes the fibrosis. And we can fix that. So when I was, just before I went over to work in Brussels, it really wasn't at all known what cells in the liver produce all these matrix proteins. Because other than in the portal tracts, there's no obvious fibroblasts, not like the skin, not like the dermis, for example. And I was doing some work on actually the blood vessels in the liver, the arteries. And I began using an antibody with this technique that I was very keen on, immunohistochemistry, an antibody to desmin. And desmin is a protein that you normally find in muscle cells. And lo and behold, when we looked for the blood vessels, not only did we see the arteries with the muscle cells in them, but we saw in the liver sinusoids these cells with long processes that were positive for desmin. In other words, in the sinusoids, lining the sinusoids, there were cells that had muscle proteins in them. And that was unexpected and unreported in those days. And it turns out that these are the same cells that you can sometimes see in a routine section if the patient or animal has had too much vitamin A. Because these are the cells that used to be called Ito cells, and we now call hepatic stellate cells. They are the cells in our body that store vitamin A, but they're also cells that line the hepatic sinusoids, and in disease they become proliferative, and they're the ones that then become myofibroblasts. Okay, so they're the sort of facultative myofibroblasts. And then shortly after that I showed that in injured liver, not only do these cells express desmin, but another muscle protein called alpha smooth muscle actin, something which we now recognize is present in all myofibroblasts. And we went on then to show that you could use antibodies to desmin and to alpha smooth muscle actin to monitor the amount of these cells in various animal models. And this is the the traditional animal model for inducing acute injury, similar to paracetamol injury, is a single dose of carbon tetrachloride. And what happens is you get loss of liver cells, and in these animals, all of these cells that are in red there accumulate. And indeed, we showed that it's not just, again, passive accumulation, but actually they were proliferating. So these cells, in response to injury, proliferate, and we showed that that was true also in the human liver, where we had some access to tissue from patients that had had a paracetamol overdose, but who then survived. And so, working with Bert Geertz and others, we were able to take these cells out of animal and human liver and put them in culture and play about with them to see what it was that switched them on. How could we, in the Petri dish, get these cells to go from the stellate cell-like appearance that you would find in a normal liver to the myofibroblasts? And that's actually relatively easy to do, very reproducible. And what we now believe is that in response to a whole host of signals, the stellate cells, which are normally full of vitamin A, because that's what part of their main function in normal liver, in response to various signals, they proliferate. And then they produce lots of the collagen. And mainly of the striated collagen, the kind of stuff that you get in scar tissue. So they go from being a quiescent cell to an activated stellate cell or myofibroblast. Over the years, we've also been interested in, is that the only pathway? Do we get myofibroblasts in liver disease from other routes? And the answer to that is probably. We were interested in a phenomenon called epithelial mesenchymal transition, long term, but that basically means under certain circumstances, as a response to injury, some epithelial cells undergo a transition to become like myofibroblasts. And we showed that that does happen to a limited extent in some forms of human disease. Now, again, we're getting into real science now, but I'm not going to go through this in any detail, but really to make the point that by being able to grow these cells in vitro, what we've been able to do over the years is to unpick the various signaling pathways which either switch these cells on or switch them off. And in particular, we're interested in some of the signals that tell these cells to undergo apoptosis or cell death, because there are some things that switch these on, telling them to proliferate or to produce lots of collagen, but equally there are some signals that will do the opposite and will induce apoptosis. And on the right here are a number of the different signals or molecules rather that we've been interested in over the years, as well as some of our collaborators. And we've been able to look at the individual pathways in the cells that lead to the binding of one of these molecules at the cell surface on stellate cells, and then leading to a change in gene transcription and the production of some other molecule, be it another signaling molecule or collagen. And again, I'm really not going to apologize for too much squiggly lines and science, but I want to show this because one of the things that we've been interested in the last few years is a signaling pathway in the stellate cells which actually protects them from undergoing cell death. So it says to this myofibroblast, you're doing a great job, let's keep going. And this is the demonstration that these cells have receptors for angiotensin. You've all heard of angiotensin? So they have receptors for angiotensin, and when angiotensin binds to the stellate cells, then it induces a number of molecular events which lead to changes in gene transcription and the production of this protein here, GAD45-beta, which is a molecule which inhibits the apoptosis of these cells. In other words, angiotensin binding to these cells protects them. But the other curious thing is, we and others demonstrated that when these cells bind angiotensin, it's an autocrine loop, so they themselves begin to produce angiotensinogen and so on. So the reason for showing that is that actually this now points the way to new treatments, because if you'll be well aware that the angiotensin system is something that we know about from blood pressure from hypertension. And there are, of course, a number of different agents that are already on the market for treating hypertension. And so our identification, and that of others, that this is probably an important pathway in stellate cells has now led to clinical trials. So there's clinical trials of losartan, for example, in fatty liver disease now, and trying to show that we can inhibit the advance of fibrosis in patients who are on losartan. It's in early days yet, and I can't tell you how we're going because it's all blinded, but I think that's very interesting, because the advantage of this is that's already on the market, so it's much easier to get it licensed for a separate a disease rather than having to start from scratch. However, there are lots of other possible avenues for new drugs, and I'll mention those in a minute. I just wanted to say one very curious piece of work that we did in the last year or two, and that was to see whether if you injure your liver, do you pass on any of the effect of that to your offspring? So this was an animal study, or largely an animal study, where a liver injury was induced in animals, and the males were allowed to recover and then mated. And we then looked at the series of offspring from that, and there was variations upon a theme. But the bottom line is that those animals, the animals who were the grandchildren of male animals that had been injured, liver injury, they were relatively protected from liver injury. So curious, and whether that has got anything to do with the human situation, we don't know. But it's a growing interest in so-called epigenetics, which I'm not going to talk about today. The message here, however, is if this is your grandfather, your liver's probably going to be fine. So I said that there are other potential targets. We've been interested in serotonin as one of the drivers for fibrosis, and a paper that we had out in Nature Medicine a couple of years ago is pointing to potentially this as being a really important target for intervention. And lots of other things now emerging as potential magic bullets for treating liver disease. The final thing I wanted to mention, though, is that other work that I've done over the last few years has actually been aimed at trying to avoid having to do liver biopsies. You might think that as a pathologist, then why would I want that to stop liver biopsies being done? But liver biopsies are a pretty invasive procedure. They're uncomfortable. They do carry significant morbidity and actually every so often mortality. And I've certainly encountered on two occasions deaths from liver biopsy, and that's tragic, but it just brings it home to us that we shouldn't be doing liver biopsies unnecessarily. So increasingly now there are alternative methods for assessing the degree of liver disease using either some sort of scanning device or blood tests. And the scanning device, which is very much in demand these days, is so-called FibroScan. Some of you might have seen this. And basically that's a non-invasive method which tests the elasticity of the liver through the skin, and it goes up the figures with degrees of fibrosis. But I've been more interested in actually blood tests of liver fibrosis. And there are a number were described over the years, but I was particularly interested in getting involved in a study which involved about 12 centres in Europe, where we got a large number of patients who had more than one liver biopsy, and they'd had multiple blood samples taken, and where we were able to measure, it was a kind of blunderbuss approach, but we measured lots of different proteins in their blood that were related to fibrosis. So some of the enzymes that were involved, some of the breakdown products and so on. And we were able to work with a very large drug company who had fantastic machines that could then put all this together, and we devised some algorithms which then mean that you can take a blood test now, you can put it in a machine, and it'll give you a number which is a predictor of whether or not you've got liver fibrosis. So it's another way of avoiding liver biopsies and giving information about just how advanced the disease is. It's not perfect by any means, but these types of approaches are really taking off now, and I think we'll see an awful lot more of them. And one of the things that's really interesting to me is that, to some extent, these seem to be better predictors of outcome, the blood tests, than my assessment of the liver biopsy. Now, I'm talking myself out of a job there, but this, I think, is definitely the way forward. And it's hitting the press now. There's all sorts of stuff that says, well, all you need to do is turn up to your GP surgery, and while you're there, you'll get a light on a traffic light system, whether you've got any injury, whether you've got any fibrosis there, and stop drinking if you've got an amber light. So that's all I'm going to say about the science. I just wanted to say one little bit at the end, though, about some of my other activities in Newcastle before I got here, because I would like to try and do some of the same here. Because I had really benefited from great supervision, great mentorship, I wanted to try and put something of that back to the next generation of would-be researchers and academics. And one of the difficulties in the United Kingdom recently has been that if you wanted to become an academic, the route to it was a bit like the London Underground map. So, and you would go in a particular direction, and then you'd find the station's closed, you had to go in another direction, and so on. So it was a very messy career path for those who wanted to undertake clinical training as well as academic training. And over the last few years, that's completely transformed in the UK, so that we developed with others and with funding from government a pathway which took you from medical school through the equivalent of the internship, through specialty training and beyond. But at each of those points, there was opportunities of combining clinical training with academic training. The idea being that after this bit here, you would end up with a PhD, you'd go back into a lectureship, you'd finish your clinical training and go into academic posts in some shape or form here, some of them being equivalent of NHMRC senior fellowships and so on. And that's worked exceptionally well and is spawning the next generation of academics there. And for me, one of the important things was to develop the early part of this pathway, because I think that had been neglected in many medical schools in the UK, and we began introducing, I mean, Newcastle was famous for having high quality a teaching of undergraduates and great clinical research, but the two were never mixed. So the students really never got a chance to see what was going on in terms of research. So we began to change the curriculum, introducing much more in terms of research awareness, recognizing that research doesn't turn everyone on, but dropping into it, the curriculum, a number of state-of-the-art lectures, plenary events which were optional but often well attended. We generated more summer projects and so on. And the students themselves then got together and developed their own a society, and then hosted two national conferences, and so great strength to them. And so if there's a desire, and we've had some discussions already, actually, desire for something like that here, I'd be very, very enthusiastic and very supportive. So there we are. I am where I am, I think, partly because of chance, partly of being in the right place at the right time, partly, I suppose, of taking risks and making choices at certain times, but also partly because of excellent mentorship, and something which I feel is so important in shaping careers. Thank you for your attention. Happy to take questions.
Yeah. Any questions?
Yeah.
I've got a question. It's
Yeah.
probably a bit roundabout.
No.
But how did you pick your mentor, or like, can you suggest any ways where we can kind of expose ourselves to finding a mentor?
Again, that was a little bit of chance. What we, in my honours year, was first year, we had to choose a couple of long essays or coursework, and I just by chance decided I would do one of the ones that Roddy McSween had on offer. And I suppose it was about the energy. This chap just had such drive, and it was always very upbeat. Nothing got him down. How do you choose mentors? That's a very difficult one. I don't know. I don't really have any easy answer for that. I think you yourselves will probably be able to identify good, positive role models, and you could probably all point to negative role models. But I think in terms of mentorship, it's quite important that it's someone you feel that you could relate to. We did have a scheme of mentorship in Newcastle where we appointed mentors for some of the academic trainees. And that didn't work all that well because actually to some extent it's got to be about you getting on with this person. But the mentor, to be honest, I suppose Roddy was both my supervisor and mentor. Mentors really often are better not to be directly involved in the supervision. It's someone who's able to work with you and help you take a step back and see the bigger picture and are you doing the right thing for you and so on. And so you need someone who is going to have those kind of people skills, that is going to be able to sit with you and not tell you what to do, but enable you to work out for yourself what's best for you. But it's quite difficult to say, well, I couldn't point in here to, he'll be a great mentor, he'll be a great, I think I know who would have the skill set, but in many respects it's up to you as an individual to kind of just be inspired by someone, and then it's someone that you feel you'd be able to open up to.
Can I ask,
Yeah, sure.
what attracted you to come to Adelaide and work here? It's a long way from the UK.
Yeah. Okay, so in Newcastle I had a great job. I was quite clinically active, still maintaining a research activity. I was no longer running my own program grants because I just didn't have the time for that, because I was also Dean of Clinical Medicine, which was a job that has some of the factors, some of the portfolio that I currently have here. And we were very happy living in the north of England. We also have a lovely house over in the west coast of Scotland, so we were quite settled. But there was something niggling inside me saying, I need a change, I need something different. I was waking up in the morning thinking, time's running out, I'm getting too old to, a big major change. And then I was approached about the job here, and I liked what I saw. I came across, I liked what I saw, and thought, yes, this is it. And personally, my children have grown up and left home and so on, so it was the right time from that point of view, but still, I still had enough energy and I was still young enough to make that big move. And so the idea has always been that I'll continue doing research and clinical work. I'm pleased to say that finally all my registration stuff has now been sorted out, so I'll start doing some work with SA pathology. I won't do a lot of it, but I think it's actually quite important for people like myself in jobs as Dean to maintain a clinical base, keep feet on the ground, and I still actually like looking